Hello and welcome back to this week's ECG of the week. Take a second here to pause the video and remind yourself of this week's clinical vignette. Now let's take a look at the ECG. Alright, so we're going to use our 6-step method that we outlined in our ECG basics tutorial that you can find on our YouTube page as well as our Facebook page. So the first thing we're going to do is look at the rate. So we'll zoom in here. There are two ways of doing this. There's the 300 method, which we'll use first. So essentially what you do is find the peaks of the R waves, and count how many big boxes are between them. So this is right before the line, so we'll go 1, 2, 3, 4, 5, 6, 6.5, let's say. And then if we move this over, it's the same space all the way across. So we can kill two birds with one stone here. 300 divided by 6.5 equals, it's around 46. And we know that it's regular as well. So we can also use the 10-second method. So what you do here is you count the number of R peaks across the whole 10-second ECG. You multiply 10 by 1, 2, 3, 4, 5, 6, 7. Sorry, not 10, 6. And that will give you 42 beats per minute. So the reason you do 6 is because there's a 10-second ECG. So in 1 minute, you'd multiply that by 6. So then you can just multiply the R waves by 6 and get the beats per minute. So we'll say there's somewhere in the mid-40s range for rate. Next, rhythm, we said that's regular. P waves, we'll zoom in here. Now I will admit this is not the best ECG for the P waves, but we do see very small deflections here. So they are present. I apologize for the size, but they are here. You can kind of see that there. So that's normal. They're just very low voltage. The QRS complexes. So if we look across, we can actually see varying QRS complexes. So in some parts they are, they're present everywhere. Some places they're abnormal and some places they are normal. So normal will be less than 120 milliseconds. However, if we zoom in here on AVR, first we can see that this QRS is longer than 120 milliseconds. So that would be 3 small boxes. It's definitely longer than that. We can also see this in AVL. So if we look here, this whole QRS complex is pretty wide. And then if we zoom out here to the precordial leads, we can see that these V1, V2, V3, and there's kind of a lot going on. We'll come back to that. And then V4 as well. It's kind of hard to tell, but I think it's pretty safe to say that that's wide. But then you do see here, coming back to V6, this is getting to be more normal. So we'll say that there are some normal as well as some abnormal wide QRS complexes. Next, we'll look at the PR interval. So if we zoom in here, the PR interval, a normal interval is going to be less than 200 milliseconds or 5 small boxes. So this is 1, 2, 3. It's about 4. And since this is about the same all the way across, we can say that the PR interval is normal. Finally, we'll take a look here at the ST segments. So this is another area where we see a lot of things going on. So we'll erase this, go into more detail here. So immediately, if we look at the precordial leads, what should stand out to you is that we have ST elevation. So, if you look here, off of the end of the QRS complex at the J point, we have this elevation here. We also have elevation here. We have slight elevation here as well. And then across some of these other leads too. We also have T-wave abnormalities. So you can kind of see this camel hump, and you can also see it down here. So this is lead 2, as well as here in AVF. So actually, it's called a camel hump, biphasic wave. But essentially what it is the presence of U waves. So since the U waves are about the same size as the T wave, they would be classified as a prominent U wave. So that's accentuated in bradycardia, which we see here. So 45 beats per minute, that's very slow. We also see it in conditions such as hypocalcemia, hypomagnesemia, left ventricular hypertrophy, and hypertrophic cardiomyopathy. So as you can see, there are a lot of things going on here. But I think the first thing that should jump to mind would be the ST segment elevation. So we'll zoom out here and review the findings. So like we said, 45 beats per minute. The rhythm is regular, so that's normal. We do have P waves, even though they're very small. The QRS complexes, they're present, so that's good, but we have some abnormalities in a couple of these leads. The PR interval is less than 200 milliseconds, which is normal. And then there's ST elevation as well as biphasic T waves or T waves plus U waves. So our interpretation here, it can't really be made just from the ECG, but taking into account the entire presentation of the patient, we would actually classify this as Takotsubo cardiomyopathy. I'll explain why. So onto the physiology, or the pathophysiology. Takotsubo is actually named after the shape that's seen on ventriculogram. So ventriculogram looks at the beating of the left ventricle. So contrast dye is actually inserted into the heart muscle. An X-ray is taken during beating, and you can actually observe what the heart looks like. So it takes on this kind of bowl shape. We'll see on the next slide why they call it this. It's actually a pot the Japanese fishermen used to catch octopi. So Takotsubo quite literally translates to octopus pot in Japanese. So the pathophysiology here, its onset is usually caused to acute stress, and it's actually reversible dysfunction of the left ventricle, and it often mimics acute coronary syndrome or a heart attack, essentially. So any type of emotional or physical stress can lead to a massive catecholamine discharge, and this results in cardiotoxicity. So we can see things such as multivessel spasms, dysfunction, and myocardial stunning. So this kind of makes sense with the presentation. That's very similar to a myocardial infarction: sweating, shortness of breath, pain in the chest. And then here we can see on the right side, so in the ventriculogram here, we see this outline that looks like a pot, and this is what the actual pot looks like. So you can see the similarities there. It's very similar looking. All right, so some interpretation tips. As I mentioned before, you're not going to be able to diagnose this right from the ECG. You're going to have to know the backstory, and it's very rare. So don't let this be something that jumps to the top of your differential list. Like I said, the first thing you should be worried about is the ST segment elevation. So that would be along the lines of myocardial ischemia. So key features with the ECG, you'll see the ST elevation, as well as you can also see QT interval prolongation, T-wave inversion. We saw the abnormal T waves, the biphasic or the presence of U waves, and you can also have Q waves. In the laboratory, you can also see increase in troponin T as well as BNP. on echo, you'd see apical left ventricular ballooning. So the ventricle actually kind of take on the shape almost that you can see here, where it's like a balloon. It's very round. And then back to echocardiography, you also see a decrease in ejection fraction in the left ventricle. And then the coronary angiography, there are usually no pathological findings. So when doing this for myocardial infarction, you would often see narrowing as well as plaques in the coronary arteries. However, if you do this to someone who's suffering with Takotsubo cardiomyopathy, you won't find this. So this is one way to distinguish it from other acute coronary syndrome. So, like I said, they're indistinguishable from a heart attack just on the ECG. It's most often seen in postmenopausal women. So our patient there was a 75-year-old woman, so this is in line with the diagnosis. Imaging studies and other measures are needed to rule out a heart attack. So you won't see any blockages of the coronary arteries usually. This is often a cause of an actual heart attack. You will see a rapid but small rise in the cardiac biomarkers. However, in a heart attack, you'd see the biomarkers also raise, but it takes much longer and it rises to a higher peak. So that's another difference of telling between the two diagnoses. And then on echo, you would see abnormal movements of the wall of the left ventricle, as well as ballooning of the apex during systole. And this is where the name comes from, that balloon shape, that pot shape. So, like I said, there are a lot of different causes, anything that really gets the stress going. So a sudden drop in blood pressure, a serious illness, surgery, medical procedure, violence, an asthma attack, bad news, a really fierce argument, financial loss, fear, public speaking. The list kind of goes on and on. You can imagine anything that causes intense stress could bring on an episode of this. So here we have an example of Takotsubo cardiomyopathy again. You can actually see here in this example, we can see the markings of ischemia in the anterior distribution. So if you look at these precordial leads, we do see ST elevation here. So in V2, V3 as well. We see a little bit here in V1. So, as well as V4. So, like I said, you'll often see the ST segment elevation. And it's other modalities that are going to help you distinguish this from a myocardial infarction. In this example here, you can also see another finding that often goes along with this. So a left bundle branch block. So if we look here at, let's see, lead V1, it's kind of hard to see here. Let's go over to lead 3. So we can see this kind of W sign, as well as a very wide QRS complex. So if you remember with the bundle branch blocks, you're going to get very wide notched QRS complexes. So this is just another thing to look out for. Again, Takotsubo cardiomyopathy will not be at the top of your differential list. This is one of the tougher diagnoses to get. So obviously, start out with something, what's common is common. If you took a look at this and guessed that there was a left bundle branch block, it would be much more likely. But after running other tests, you might come to the conclusion of Takotsubo. So just some takeaways. You need to make sure that you take the patient's whole presentation into account. Treatment, you would start with the treatment that's most common. So for our patient here, you would be guessing ischemia. So essentially what you'd start off with is beta blockers and ACE inhibitors or an ARB. Most often there will be no sign of coronary artery involvement, so this is kind of one way to distinguish it, as well as a quick small rise in cardiac biomarkers as opposed to a longer, higher rise in things such as an MI or acute coronary syndrome. The good news about this is that there's a good prognosis if this is managed and stressors are avoided. So if the patient takes care of themselves and avoids stressors that they know might cause this, there's actually, I believe, a 10% chance of this happening again. So it's a very good prognosis. So that's all for this week. This was one of the tougher ones, but we know you guys are very smart. So thanks for tuning in, and make sure to check out next week's video. Thanks.